Hey guys, so today we're going to be doing HIV and we're going to talk a little bit about the background and then some oral manifestations, so really characteristic HIV oral manifestations and then other associated ones, and then talk a little bit about the treatment as well. So don't forget, download the poster in the link below and let's get started. So background of HIV is a retrovirus. It is called the human immunodeficiency virus. There are two types of HIV-1 and HIV-2, but the one that's most common, especially in the UK, is HIV-1. Transmission-wise, we know this, like sexual fluids, pregnancy, breast milk, blood. The tendency for the intravenous blood sharing has decreased a lot. That's a random fact you want to put down. And the typical treatment is HAART, so this is hyperactive antiretroviral therapy. Okay, so a tiny bit about how it works is that you get exposure to this virus. It goes into your blood and it attacks lymphocytes, and I think these are lymphocytes that have like CD4 little thingies sticking outside of them. So it goes into that, it attaches, and then it releases viral RNA into that T cell, so the T helper cells, releases viral RNA into it and a few other proteins that then go and attack the nucleus of that T lymphocyte, and then does something to the DNA, messes it up, mutates it essentially, and then you end up with this T lymphocyte producing viral DNA. I think it's DNA. So they use reverse transcriptase, turn RNA into DNA, and make this viral DNA, which then is transported outside and can go and affect other T lymphocytes. However, one key thing about how it spreads really quickly, how it like becomes really bad really fast, is not because you get so much, not many T lymphocytes are actually making viral DNA. What happens is that a T lymphocyte that is very virulent will suddenly realize that, oh, I'm making viral DNA, let me destroy myself because I'm killing myself. So then he will destroy himself, and then a typical apoptosis, you'll have a destruction of a cell, and then macrophages come and they clean up the debris and carry on. Happens all the time in our body. But in an HIV-infected T lymphocyte, he'll break down, but then what he ends up causing is as a severe like inflammatory reaction, and then you get other T lymphocytes saying, oh hey, look, it's inflamed, let me go fix that. But then what actually happened is that when he destroyed himself, he actually released a lot of viral DNA, and then all the T lymphocytes that come and help out to remove this inflammation, they end up getting infected. So that's what happens, and generally the whole point of HIV is that you get a reduction in the ratio of T helper to suppressor cells. Right, so once a patient or a person is exposed to HIV, what happens is that within 2 to 4 weeks you'll get a severe fever with like cervical lymphadenopathy, fever, sweats, malaise, the whole thing. And that will last up to 2 weeks. And then what happens after that is that they go through this 8-year period of clinical latency. So very few will go through a 25-year period, but majority is this like 8-year clinical latency. So clinical latency means what? It's you have a virus in you, but it's not showing any symptoms, but you are still infected. Now if you compare this to virally latent, which is found in shingles, so you get chickenpox and then you get a latent virus, so a virally latent thing in your trigeminal ganglion, and you are clinically asymptomatic, so you're clinically latent, and then you're also not infective, so you're virally latent. But in HIV, you get this period of clinical latency, so it's 8 years of no symptoms, but you are still infected. Okay? So we have exposure, acute illness, clinical latency, and then throughout this 8-year period is when you're having all this destruction and T lymphocytes getting infected, and then your T cells basically keep dropping, and you end up not able to attack other diseases. So you have decreased immunity, and then you get an opportunistic infection, and that's what causes the death. Okay? So it's not the HIV, it's not the AIDS that causes the death, it's just severe immunocompromisation, I think that's a word. But you're severely immunocompromised, and then some other opportunistic infection comes in, and that kills you, because you can't fight it off. So right here, we'll talk about staging. So 3 stages of HIV, so stage 1, 2, 3, over here you'll find like the CD4 count, so you do a blood test to test for CD4, and you usually associate, like you accompany that with HIV viral load, so they'll do a viral load test, they'll do a CD4 count, and then they could also do an immunofluorescence where they'll see antibodies, but I think sometimes the antibodies don't show, so they usually rely on that CD4 count. Now, stage 1 and 2, so we have here greater than 500 cells per microliter, I think that is. And then stage 2 is 200 to 500. And then stage 3, so the process of moving from stage 2 to stage 3 is when your CD4 count goes below 200. Now, once you've gone below 200, you are very immunocompromised, and you develop what they call AIDS. So this is acquired immunodeficiency syndrome. Yeah, so here, antibodies appear 6 to 8 weeks after infection. Alright, so that's a little bit on the background. Now, this period right here, this is when you start getting your oral manifestations. So the first signs of AIDS is usually like candidosis, because it's an opportunistic infection in an HIV patient, and you're like, might be, you might be dropping down to the point of AIDS. Now, if you don't take any treatment at this point, you have like 2 years to live. But with HAART, so the treatment, hyperactive antiretroviral therapy, you can increase your lifespan, you can make it a bit more manageable, and then possibly like decrease the amount of oral manifestations and just lengthen your problematic free. I don't know how to pronounce it or say it. Anyway, moving on. Characteristics to that are very associated with HIV. So oral manifestations that are very characteristic of HIV. There was an exam paper on this. It's not too bad. Okay, so Kaposi sarcoma is the most common one. It is a malignant lesion. So it's the flat purple plaque. You usually get it, I think, in the palate. Yes, palate. And then it's also a multifocal one, so you can get in the lymph nodes as well and on the skin. But the intraoral site that we will see is on the palate. Kaposi sarcoma and then lymphoma. So these are the most, like, the 2 dangerous ones. So lymphomas will present as fine, soft, painless, and if you like traumatize it, it will ulcerate. And there are 3 main types. So there's a plasmablastic lymphoma. So it's associated with both the HIV virus and EBV. So if you remember back, EBV is Epstein-Barr virus, so HHV4, and it's also associated with hairy leukoplakia. So, fun fact, when you're moving from stage 2 to stage 3, you get a severe, like, you get a really bad opportunistic infection with EBV. And that's what causes all these HIV-associated lesions. So plasmablastic is very, very typical to HIV, and it's probably very rare to get it in a non-HIV patient. Burkitt's and then B-cell lymphoma. Again, intraorally, these are not common lymphomas. You can find them in other patients as well, but intraorally is very rare, and I think you can get them in your salivary glands. Okay, so when we do salivary glands next, I'm hoping you'll find that lymphoma is in that one. Hairy leukoplakia, we've talked about this several times, vertical corrugations on the lateral border of the tongue, and if you took like a in situ hybridization, you would find EBV in the epithelium. HIV-associated gingivitis, so this will be patient comes in, they have very good oral hygiene, and you can't really find any other reason why they're suffering from gingivitis, and then you look for other immunosuppression, like reasons for immunosuppression, and it could potentially be because of HIV. Typical representation of this is if you have like a red line within the gingiva, and they call this linear gingival erythema. I think it's also very associated with Candida, but don't take my word on that. But it's always used with HIV-associated gingivitis. HIV-associated salivary gland disease, so it's typically in children. You'll get bilateral enlargement of your parotid gland, and it'll be very soft. I'm not too sure if it's painful, but if you took an ultrasound, you would find multiple cysts within the parotid gland, and that is HIV-associated salivary gland. So it's also called salivary cystic disease because you find the multiple cysts. Now, right here in the corner, I made a tiny mistake, then I fixed it. So chronic parotitis, if a child is getting recurrent infection of the parotid gland, and it could be suppurative, and if you took a culture and you found EBV or CMV, so cytomegaloviruses, HHV5, then the child is likely to be immunocompromised, and because it's associated with EBV, you're thinking HIV. Okay, and then bacterial infections that you don't normally find in the mouth, then you're thinking, okay, again, immunosuppression. If you find E. coli in the mouth, you're like, this is not usual, this shouldn't be here. But the fact that it's there is because you are so susceptible to opportunistic infections that you're getting these random infections. This is worrying me. I think you have something like HIV. You do the tests, you find out. So these are the characteristic HIV manifestations. However, they're not like the most common ones. They're just very characteristic to HIV. The most common HIV oral manifestation is Candida. So the first oral sign that you'll see in a patient with HIV moving to stage 3 will be Candida, and the two types are erythematous, is mostly associated with with HIV, and then pseudomembranous. Persistent recurrent ulcerations. So of course, if you find a persistent ulcer, you're thinking, okay, I'm going to biopsy it and find squamous cell carcinoma potentially. So that's why it's important that you biopsy it. But if you're getting it's very typical that you get a major aphthous ulcer. So major is always, or typically found, soft palate and oropharynx area, dorsum of the tongue even towards the back, and it's recurrent, so it heals, it scars, and then it happens again. This is a sign of HIV. So again, you do the tests. And if you can't find any other etiological factor, like if they're not anemic, for example, then, I mean, you'd probably ask for all the tests at the same time. But you would find that probably they're moving down to less than 200 cells, CD4 count. Necrotizing ulcerative perio. So this happens in other patients as well, so smokers. And the thing is that in HIV patients, you might not find the common etiological factors for NUP, so they'll have good hygiene, maybe they won't be smokers, but then you'll have like severe destruction of the alveolar bone, and you'll find gums and their like the trench mouth look, and you're thinking, again, HIV patients, because they're immunocompromised, they have an increased risk of developing that. On top of that, they also have an increased risk of developing the secondary herpes zoster shingles, just because immunosuppression is one of those instigating factors for reactivation of that latent virus. And then thrombocytopenic purpura, I skipped here, herpetic stomatitis is just, again, increased risk of getting it, you know what it is. Thrombocytic purpura, we've talked about this in tongue lesions and the colored lesions. So it's just purple patches, essentially. You can get them in the buccal mucosa and elsewhere in the mouth. And what happens is that in an HIV patient, you might mistake that for a Kaposi sarcoma because it's also a purple patch, essentially. So you want to make sure that you biopsy and make sure that it's not malignant. And then just reassure the patient. But then that's a sign to you that, oh, okay, let's start like giving you treatment or changing your treatment. Moving to which, resistance is very common in these antiretroviral therapies. So it's like antibiotics, you know, if it's not working, bacteria become resistant. You have to constantly keep changing the antibiotics. It's the same thing, you change the antiretroviral medication because, for example, if you find that you're giving the person the therapy and it's not working, and they start developing, like it was working, and then they start developing, you know, candida and whatnot, you're thinking, oh my gosh, it's not working anymore. It's probably become resistant, and so you want to keep changing it to avoid resistance. Heart, a lot of the medications, they have lots of bad side effects, and then one of the most annoying one that probably affects the compliance of the patient taking it is the development of like papillomas, and you get warts in the mouth. And so you can manage it with excision, cryosurgery, laser, and whatnot, but it's recurrent. As long as you keep taking the medication, it will keep happening. And then other things are like altered taste, xerostomia, perioral paresthesia. And then you can also, a lot of the medications I saw were associated with Stevens-Johnson syndrome in the book, which is, remember, the really severe version of erythema multiforme, which was the crusted ulcers on the lip and the target lesions on the arm. So yeah, compliance is usually a problem with these HIV patients, and then spread. So patients might think that, oh, okay, see, I'm not symptomatic, everything's fine, and then they go and they do what they do, and then they keep spreading the HIV infection. So it's very important that you communicate with them. And you know, let them know that, look, you are clinically latent, you are not virally latent, so please don't spread. Yeah? Pretty much it. Cool. Thanks for watching.